Good afternoon, everyone who's joining us. We will get started in just a moment as we allow for our attendees to log in. Good afternoon, everyone. Thank you for joining us for our Refugee Health webinar series. Today, we will be focusing on medical considerations in providing care to adult refugees with our speaker, Shelley Paquette, who I'll introduce in just a moment. First, I just have a few disclosure slides. We are CME approved for this, so it's 0.75 category 1 AMA credits. And we will, Birdie, who's on with us, will be sending out an email to our registrants or to our attendees on how to claim that credit. The credit must be claimed within 30 days or else UVM will not let you claim the credit. This is just a disclosure slide saying that we have no disclosures, financial or otherwise. And this is our website that we've put together. Andrea Green, who's on with us, has really been the driving force behind this whole series. So we thank her and give her a lot of accolades. This is our agenda or a schedule of events. Actually, this is an old slide, so I included the last webinar, but going forward, these are all of our webinars that are scheduled. All these sessions are recorded, and so we put those up, the recordings up on the website and the presentation, so that's available to folks after the fact. And then there's a number of resources on refugee health that people can look at their leisure. So with that, I would like to welcome and thank Shelley Paquette, who is a family nurse practitioner at the Community Health Centers of Burlington. And just a little, she's fabulous. I've just gotten to talk to her and gotten to know her for just a few minutes. She has really committed herself to working with underserved and vulnerable populations in the US and abroad. So thank you, Shelley, for coming on and doing this. We really appreciate this, and I'm going to pass it over to you.
Great. Well, nice to meet you all. Let me just share my screen real quick here. Did I do it? I did it. Okay. You all can see it. We're good. Thank you so much for having me. As Stephanie mentioned, my name is Shelley Paquette, family nurse practitioner at the Community Health Center Burlington, and I'm super honored to be presenting on my area of professional passion, medical considerations in primary care to adult refugees. A little background and history. I actually got my start providing refugee healthcare 13 years ago, or 14 years ago, as a registered nurse here at the Community Health Center. We had a new American clinic, kind of similar to what we're doing now. And that ultimately informed my entire career path in public health and working with refugee and immigrant populations. So it's like very full circle and exciting for me to be doing this. I currently run a newcomer clinic at the Community Health Center that focuses on healthcare for new arrivals, refugees, and immigrants in their first year in the US, and also have a panel of patients of kind of wide range, have been here in the US for a few years to many. So our goals today are to discuss ways to provide ongoing care to adult refugees after they arrive in the US, with considerations on how to approach chronic care, routine screenings, model of care delivery that we found successful. I'd also just like to take a second to honor that there are a lot of perceived barriers and fears surrounding refugee health. Like, will you have enough time? How to use interpreters? What if they have a lot of medical concerns that you don't feel like you have time to address? And I can appreciate that it can feel overwhelming at times, but I also just really want to highlight that it can bring so much joy to see the resiliency in people, and can be super rewarding. So this is my work doing this has really kind of what kept me going during COVID. And I'm hopeful by the end of today that you'll have some tangible tips and framework to reduce those barriers and have you kind of looking forward. So yeah, we'll chat about chronic care, talk about some barriers to care and tools to manage them, vaccine and preventable care catch-up tips, and what's kind of what we've seen work. So to start with barriers that we keep in mind when we think about ongoing care for adult refugee populations, I think of language, I think of culture, higher rates of mental health disorders, and varied explanatory models of mental health and chronic disease, transportation, pharmacy navigation, housing, financial, family obligations. I don't know if we always think about the transportation, housing as barriers to general barriers to care, but also just general barriers to chronic care and hypertension management and diabetes management and follow-up. There's kind of, it's multifactorial when we're thinking about how to best take care of people. And so we try to think about and consider these barriers when we lean on our community partnerships and framework for like establishing care, when we're providing education, deciding how frequently to see people. We don't want to overwhelm them and take them out of work, but we also really want to engage them in primary care. And so those are kind of the barriers that we keep in mind. So I'm kind of like thinking about starting today, thinking about post-domestic health assessment. So many of you likely already know, or if you don't, most refugees have a domestic health assessment upon arrival, usually within 30 to 90 days. And I think Dr. Andrea Green did like a talk about that. So I'm not going to dive too much into it, but it is a required assessment. And we work with USCRI on getting our folks established with primary care after that. So I think there's a lot of resources and supports like on the CDC website and kind of on the internet about the domestic health evaluation, but there's less guidance on what to do once it's completed. Like, okay, so the domestic health assessment's done, now what? I think the first year after someone arrives is a really crucial time to wrap them up in services, but it also can be an overwhelming time. So providing multiple touch points to engage in the healthcare system can be really helpful. We opt to establish care for folks after they've had their domestic health assessment, mostly so that we can really reinforce like what's been done there, make sure there's nothing we need to follow up on in terms of vaccines or additional testing. And then like reinforce, like if they have hepatitis B or latent TB, that they know when their follow-ups are and that they're able to get to them, and that just that sort of care coordination and making sure they're not missing that. There's always expectations or special considerations. So we work closely with our partners to get people in for acute conditions quickly as well. I was thinking of someone that was seen for their domestic health evaluation, and their blood sugar was like 600. And we were able to kind of coordinate between infectious disease and USCRI and actually get that patient seen the next day and get them started on like insulin in the office so that they didn't have to go like through the emergency room. And so there's special considerations where like obviously urgently we can get people in, but yeah, so these are the post-domestic health evaluation topics that I thought we could highlight. So what we do to establish care and what we found helpful in streamlining that, the chart preparation that goes on, what we do at our initial visit. And I say initial visit because usually it's like 2 visits that we take to get all of this done, but kind of initial visit idea. And then follow-up visits, physical exams, chronic care needs and ongoing management, and then kind of special considerations. So our scheduler, we have a dedicated scheduler that works with the folks at USCRI to get the initial paperwork and release of information completed quickly to reduce barriers. And I just want to highlight how important like partnering with the local resettlement has been for us, and how how helpful. So, you know, the USCRI, they carry the overseas documents and get them to us, as well as the infectious disease. This is kind of what the overseas document I'm talking about is. Sometimes we get them, sometimes we don't, but that's something that they help get to us, that we make sure to upload like information and make sure it's up to date. And they also do some initial education around healthcare. So that's, you know, things that we reinforce later, but yeah, they like basically the moral of this slide is that we couldn't do it without like our partners, and that's really important to connect with them. So so you're likely your local resettlement agency is doing some preliminary education and care coordination. And yeah, so that's that forum I'm talking about. And then I want to introduce you to our team. So we have a small team of folks dedicated to refugee healthcare at this time. I'm a bit of like a systems nerd and believe that like we really need a good system in teammates to deliver healthcare across populations. So I just want to kind of share what's worked for us. I'm the one provider right now who's seeing, who's doing like a new American clinic where I'm seeing new folks. And I see around, I don't know, 6 to 8 patients in my newcomer block. It's a half day. And it's a hybrid of brand new folks and follow-up visits. My medical assistant is incredible. She assists with the chart prep, which I'll actually give you an example of just in case you find it helpful. And making sure that we get uploaded and abstracted like meaningful information. So all the past vaccines, the past lab work, we don't have Epic, so there's a little bit more time involved in that than maybe folks who could just blow it in, but yeah, she helps with that. And then obviously like rooming patients, getting labs and vaccines. And then the behavioral health provider is like what I think as kind of like the, you know, the most special part of our clinics, because we're able to provide mental health screening for everyone, basically at every visit if needed, but everyone who's a new person meets our behavioral health provider. And she does a detailed mental health evaluation, and I'll share which one we're using. And then some folks from USCRI are usually able to attend and help with care coordination. And then our schedulers helped reduce no-shows a lot. So coordinating getting folks in a timely way can be challenging, especially in the current climate where a lot of people aren't taking new patients, and yeah, and there's a lot of stuff going on for these folks. So we typically have like, I don't know, a very low no-show rate, maybe 1 max. Usually everyone comes. And then we have our dental team, which we don't work directly with, but they do attend monthly meetings with us to help us find ways to meet the limited access, but extreme need in our community for dental care. And then leadership. So our initiative to like get this newcomer clinic going started about a year ago, and I don't think we could have done it without leadership really kind of stepping up and saying like, yes, we're on board and we have buy-in to help with this. So I'm going to do a little case study to kind of like show what the first couple of visits look like, and provide some information like common things that we're seeing and following up on. So we'll say Mohammed, the fictional person, 30-year-old male from Afghanistan who arrived in the country into Texas and relocated to Vermont. Had domestic health screening here, no past medical history prior to arriving in the US, has like COVID vaccine card, but that's it. We don't have any other old records. And we have the domestic health assessment that was done a month ago. And this is what my chart prep looks like. So this is what Nazra, my medical assistant, will get into the chart for me, and that we can just review prior to seeing the patient so that we're making sure we're not missing any follow-up from the domestic health assessment. I think if you can do it in advance, it's really helpful. So Nazra, like between patients or like earlier in the week, or if she has downtime, will try to get these prepped. And then that way you can focus more on the concerns that they have in introducing folks to healthcare, the healthcare system and primary care. And so looking at this, Mohammed has a positive QFT, TB quantiferon, but a normal chest X-ray. So he's a diagnosis of latent TB. He had serologies positive for hepatitis A, measles, mumps, rubella, and varicella. So he's immune to all of those. He doesn't have HIV, hep C, syphilis, schistosoma, or strongyloides. All of his hep B testing was negative, and he got a hepatitis B, his first vaccine at the during his domestic health evaluation. H. pylori was positive. OMPs were negative, and he has follow-up scheduled for latent TB treatment through UVM. And then this is just kind of a reminder to ourselves, did we update the immunizations, and what are we likely going to give when we see him? And then we get to our primary care visit. So we're meeting Mohammed for the first time. He's had his domestic health evaluation. His URCRI case manager and our schedulers have coordinated to get him in for a 45-minute new patient visit. They've requested an in-person interpreter, and medical chart prep is all set. We do a 45-minute visit for our initial visits. We try to have in-person interpreters, which tends to speed things along. It can be easier to tell whether people are understanding the information that we're giving them. And, it really generally seems to make visits go smoother. At this time, we don't have in-person interpreters for all visits, but physicals, PAPs, new diagnosis, like new diabetes, new hypertension, it can be really helpful. I think there's an upcoming training on working with interpreters, which I hope if you're interested in this, that you attend. I'll quickly highlight for providers. I think it's really important to work on the speed and the cadence of delivery information. For example, frequent pauses, one concept at a time. I may not be practicing that right now because I'm probably talking fast, but I think that that's really just important things to keep in mind. But there's a whole training on it, and there should be good training on interpreter, how to use medical interpreters. And then as for introduction to primary care, this may be a novel concept for many people. It's not the first time people are hearing about this. Since arriving in the US, folks generally have gotten the introduction to healthcare through their local resettlement agency. But I use this time to reinforce what they likely have already heard, emphasize relationship building, getting to know each other, what the emergency room is for and how to use it, how to get an appointment here, my name and phone number, how to reach someone. I like to give a little card with our name because inevitably when they end up either at a different organization or at the hospital, they know who their primary care is, what their name is. I've gotten feedback from specialists and other providers that patients are unsure who their primary care is, what primary care is. And so this is our just initial attempt at trying to just introduce that concept. We typically pharmacy is its whole thing. And we talk about it a lot, what pharmacy they're using. And we do that in conjunction with the case managers from USCRI if we can. It may seem simple, but it is so crucial. Many places people are coming from, they get dispensed medications either in the office, oh, you're done your visit, here's your medication. Or they can just buy things over the counter. and they write down what they need and they go and they purchase it. So the idea of having a pharmacy that you go to may be novel, and saying, okay, I sent this medication to the CVS pharmacy is like simply just not enough. Tips are to identify someone that could help them get it. Like, do you have a family friend? Is there someone else that, that has also picked up medications that you could ask to help you? We rely a lot on our USCRI colleagues to help them get their medications. And so I try to use this time to explain what a pharmacy is and how to use it, although time constraints do make this more difficult. So it's a team approach. Whoever can kind of do the pharmacy spiel, whether it's me, USCRI, we just got a new case manager working with us, so I'm hoping maybe she'll help with that. But yeah, so important to touch on it. It really, like, it has to happen at that first visit. Otherwise, you're going to see them back and they're not going to have picked up any medications. And yeah, and then I'm not sure if it's the best use of my time, but I like to think that it's helping me relationship build and become a trusted person for people. So yeah, when people arrive in the first couple of months, they're meeting so many different people: WIC, Social Security, the lab, primary care, infectious disease, dental, USCRI, housing case managers. Like, it's so overwhelming. So if I can be like the point person, then that's great. And if they connect with someone else at our organization, that can be like a safe person for them to talk to and kind of like, okay, this is primary care and this is whom I'm connected with. I think that's really important. And taking the time to do this goes a long way. So it takes a little time, but I think it's worth it in the long run. And I also just, like, my little spiel is that I always just make sure to put a dental referral in. I don't know about dental access in other parts of Vermont, but here it has been really hard and it's a really big need in the community. So from our end, I'm just trying to get that entered into everyone just the first time I see them, so that that ball is rolling. Yeah. And mental health screening. So this has been such a, important part of our care. And so we are doing mental health screening with our behavioral health provider at every visit, or at least at their initial one, but often at follow-ups as well. And, just like in many cultures, the idea of mental health care is reserved either for like people with severe and persistent mental illness, or doesn't necessarily mean what we think we mean by mental health. So using terms such as like managing stress, dealing with like really difficult, hard things that have happened in the past, the connection between the mind body are ways that we've started in introducing this concept. And I have to say, like, it's been really, eye-opening. Like, I worked with a lot of refugee populations in the past, but using the RHS 15 screener, kind of reframing the way we're talking about it, has led to a lot of buy-in around talking about this. So we've had many people say yes to counseling. We've had many people just agree to talk a little bit more, practice some grounding with our behavioral health provider. So I'm like really excited about sort of starting these conversations around what we call mental health, but about stress management, and then the way that stress affects our body. So we can refer directly for counseling when access allows, see them back in clinic, and just have our behavioral provider pop in again and just do some brief interventions. We have like we can refer to a CBT insomnia group that goes on, as well as start folks on medications. So I've had success with SSRIs, like sertraline, Lexapro have been kind of my go-tos. But I've been using prazosin a lot to target nightmares and sleep, and then also mirtazapine. So I've seen a lot of people with weight loss, which they attribute to stress. And so they're making that connection themselves, that they are noticing significant weight loss. Is there something wrong medically? We kind of chat about that part, and then they think, I think that it's stress. And I say, you're you're probably right. So, so mirtazapine has been helpful just for the sleep and appetite part of things. And I'm seeing people pretty regularly back. So I don't know, timely referrals to mental health services can really help people live a more productive and healthier life following resettlement. So important to think about. The RHS-15 is a tool that screens for common mental health conditions, anxiety, depression, PTSD, adjustment disorders, and coping, but it does not screen for domestic violence, substance use, or like mood disorders. And the interesting thing about it is that it is it's available in multiple languages. So it's listed here on the slide, but it is it's available in a lot more languages than other screening tools. And it's not one where you would want to, see it in English and have an interpreter interpret it into another language. You really need to use the interpreted version of it. So that's kind of the one challenging thing, is that there's not an interpreted version in Pashto. So for our Pashto speakers, we've been using a different screening tool, the Afghan symptom measure. Lauren was out today, so I can't remember exactly the name of it, but she's been using the other one, but still kind of similar concepts, talking about like stress and distress and sort of trying to identify trauma and underlying depression and anxiety. So we try to split partners if possible. I know people often come with their partners, but we just do try to split them if possible. And I try to meet with the behavioral health provider prior to seeing the patient. So usually she'll try to see them first. And so for Mohammed, he tested positive on the RHS-15. He was endorsing difficulty sleeping, stays up to talk to family. His children and wife are still in Afghanistan, so that's a really big stressor. He feels responsible financially for them. So he's sending money back. He has worries that the Taliban may attack his family, but he's interested in discussing ways to help manage his stress. So Lauren, our behavioral health provider, met with him and was able to do some brief interventions around stress management and get him kind of queued up for like some short brief counseling when there's openings. And then I'm making the plan to discuss medications with him when I go in. I'll take a sip of water. Make sure I'm doing okay on time. So so this is what the other, kind of switching gears a little bit, other medical history stuff that I think it's important to gather. And I just have like a few anecdotal things that are important to think about when we're doing the history. Some of it's population specific, but in general, I think we have a habit of over-conservatizing refugee populations. So in particular, assumptions regarding their sexuality, fertility intentions, openness to contraceptive use, substance use, monogamy. So I think it's still really important that we're asking these questions, even if we're being aware of the assumptions that we have and making sure that we're still having conversations. For example, ongoing STI screening is still really important. I carried an assumption around around monogamy in the Muslim population, and so I was missing opportunities, I think, for a little while for STI screening. So just my own thing that I've noticed that I was doing. So asking about caffeine. So USCRI was noting kind of a lot of social Monster and Red Bull consumption. So disproportionate to other populations that we've worked with. And so basically people have been drinking lots of energy drinks, and likely dating back to the US time in Afghanistan and some contracts that they had with Monster. It's its own little thing. It's interesting. If you're interested to read about it, you can, but talking about this is really relevant because I've seen anxiety, GERD, sleep all improve with quitting energy drinks. And then also just want to note like reproductive health goals. USCRI has noted many women interested in contraception to pause childbearing, like recognizing that this is a really stressful time in life and that that getting pregnant may not be a goal. So we just use the one key question, do you plan on getting pregnant in the next year? And if it's urgent and people are like, I do not want to be pregnant, I just arrived, like get me birth control now, we arrange with our midwives to try to get them a LARC. But otherwise, if they wanted to talk more about it, we schedule them for follow-ups. It's a lot to cover in one visit. And the other kind of other interesting thing is that with the Afghan population, alcohol is liquor and beer is separate. So it took me a really long time to learn that. I was asking people if they were drinking alcohol and they said, no, never, but realizing that they were consuming a fair amount of beer. So something to, just a little anecdote. So for Arman, his past medical history, some hearing loss after a close explosion to a bomb. Mom was healthy, father deceased of stomach cancer, not on any medications, substance use, like we said, no, but learning a little more, actually beer. Beer was something that he was using. Doing 2 monster drinks a day, but that was a reduction from 5. So he's feeling pretty happy about that and had already kind of had preliminary conversations about caffeine use. And exam, my first time meeting folks, I really do a focused exam since we're focusing on so many things. So getting him back for a physical, I think is really important. And for example, today, kind of borderline blood pressure, he had like some scarring in his ears. So he needs, like, I was going to refer him to audiology for a hearing evaluation, dental caries. So we got that dental referral placed. But, you know, a bigger physical and talking about preventative care is a really big priority. And then I just wanted to share, this is what my plan looks like, where I can share, you know, I just take a picture, or when this is shared, if it's helpful for you and your organization, these are the things that I'm considering post domestic health evaluation and like within the first year. And so for Mohammed, you know, positive TB screening, we already talked about like some latent TB diagnosis, but that's followed by UVM. So I always offer that if there's barriers to getting there, we can take over that here. H. pylori, so we want to do a test of cure and make sure that his triple therapy worked. And then just kind of my spiel about mental health, he declined medications, but we did discuss monster drink reduction to target sleep. And then, you know, what he had evidence of immunity to the MMR, varicella, and Hep A, but we do want to give a Hep B dose, number 2, and some Tdap. So, and then scheduling a physical. So I mean, you know, this is my plan on latent tuberculosis, if you find that helpful. I think that treating latent tuberculosis in primary care is appropriate. I think that we have the tools to do it, and I think that it encourages continuity of care, but they're also like, so there's good trainings on the CDC website, if that's interested to you, or if you're rural, and something to consider. It can be intimidating at first, but I think is very doable for primary care, and reinforces like this is your medical home. And then this is just my H. pylori, just my little spiel on that. I think Laura Cato is giving a talk on that in like a week. Hopefully will attend. It's H. pylori is really difficult. We see a lot of it. It's difficult to treat. We used to ask for universal screenings of newcomers, but we're moving away to just screening symptomatic people. But do keep it in mind, like years down the road, H. pylori really is, it's prevalent and can cause significant symptoms for folks, but there are a lot of asymptomatic cases that don't necessarily, I don't believe that you have to treat asymptomatic cases at this time. And if we do see a patient, like we do the test of cure after domestic health evaluation. And so if we do see a positive one, and it's We coordinate with Lakeside Pharmacy. So we partner with our pharmacy to get things bubble packed for people. And then we have them come in for a nurse visit and review how to use it. And we still run into problems of incomplete treatment, failure treatment because of side effects. So it really is like an important, it's not just like here writing this prescription and go take 14 days of 4 meds a day. Like it's can be more involved in that, and there's more to think about. So lots of side effects. So vaccine catch-up is, I think, a really big part of what we should be doing, not only just because it's good care, but it's also just like it's a touch point, and it's something that people are used to, like they've gotten vaccines before they came here likely, and it's something that can be kind of like the lure to get them back in. So they typically receive some age-appropriate vaccinations overseas, but but not always, or they don't have to, or they may not have records of it. But you can, if you have overseas documentation and it's in line with the ACIP guidelines, then it's valid. Serologies for many preventable illnesses are completed during the domestic health evaluation, or are just they're cost effective in general. So can be a way to screen for like varicella and MMR. People get a Hep B surface antigen prior, like the lab prior to coming. And so if it's positive, they're counseled, but if it's negative, they typically get their first hepatitis B. This is like with the Ukrainian population, I have not seen that. I haven't seen really any records. And with the Afghan population, it's really touch and go whether we have documentation of that first Hep B overseas. And yeah, tetanus. So if people previously did not receive a primary vaccination series, so they don't always know, or maybe that they don't have recollection, it really should be a 3-dose series, like a catch-up series. So just make sure to get that started. I asked our medical assistant who does a lot of our green card paperwork, and he says that's the one that typically gets missed the most, that he has to try to catch people up on before finishing their green card paperwork. And then introduction to what a physical is at the new patient visit. I try to give a spiel on that idea of keeping people healthy, and preventative care is like pretty new. So I schedule everyone for a physical with either myself or their PCP, or if I'm worried about access, sometimes with the midwife, at least to get the PAP done. Sometimes that visit's a lot of education and informed consent, and so the PAP doesn't always happen at that time, but at least conversations around the importance and what we're doing, and showing all the supplies and making people feel safe if we can. And then I try to get preventative screenings ordered as early as I can, since they book really far out, and we hope to get people in while they're insured. For example, like colonoscopy, mammogram, specialist referrals done at the physical or at one of their follow-ups. And shared decision-making can be a novel idea. In general, people really want to do what we think they should do. And so it can feel kind of uncomfortable and require an adjustment in practice. So, coming from countries where they aren't given a lot of choices, taking the time to discuss risk benefits is really important. And I see people usually within a month for follow-up, where we can finish what inevitably we didn't get to at the first visit, because let's be honest, like I've talked about our visit for 45 minutes. So we don't always get to all of that. And then, in general, people have poorly addressed needs, and it can take a while for that to unfold. So ultimately seeing people monthly is ideal. They're in general, in this first year, they're in a state of overwhelm. There's a varied sense of what's possible in addressing their healthcare needs. So for example, people might not mention their pain that they've had for 20 years because there's nothing they can do about it. Because they perceive there's nothing they can do about it, versus like high expectations of what the US healthcare can do, and having like over, like superhero ideas of what the US healthcare system is. And although like I've talked a lot about things that refugees may not know about or have experience with, it's It's also really critical that providers and all the caretakers recognize that refugees come with a wealth of life experiences and strategies and skills that they've developed to survive and keep themselves and their families as safe as possible under incredibly difficult circumstances. So it's important to not confuse their lack of knowledge of the healthcare system with, a lack of knowledge and resourcefulness. So it can be useful to ask about how patient addressed particular health concerns in the past, in their previous homes, and figure out approaches that build on that and work like in conjunction versus having it dismissed or replaced kind of their customary practices. And I think I'm running out of time. Okay, I'm sorry. This is my kind of last slide, and we could spend an hour on it because stress and chronic disease and somatic concerns are so much of what we see. So I was at the North American Refugee Health Conference, and one of the speakers, Dr. Cronkite, was an incredible talk that he gave about the big three: chronic pain, fatigue, and dizziness. They're the concerns we see frequently and may not always have explainable diagnoses. I also think these are the concerns that, like, as providers, we see in our schedule and it like gives us heart sink, or it can be like this feeling of overwhelm. So taking the time to hear people's story, give the opportunity to get the story out. You're going to get so much further if you take the extra few minutes to really hear what's going on. Like pausing, tell me more, what else, like really kind of wringing it out can go a long way. And then while you're doing that, also listening for red flags, like things that are really concerning about their new fatigue or their dizziness that you can like make action on. And then listening for trauma, listening for like ACEs. And we're used to this, the general population have these concerns, but the incidence is just much higher, especially for functional somatic syndromes. So I don't have the numbers, but could certainly get them. And so these are some of the like memory loss is also something that I've been seeing a lot of recently. I think in just the really acute trauma populations, like with the fall of Kabul and the Afghan population, I've seen so like finally arriving here, things getting settled, and then memory becoming an issue. So I involve the behavioral health team, I get routine labs and imaging if red flags, and then treating underlying conditions like stress and nutrition and sleep. And those seem to be like sleep can be a culturally accepted framework that's a good starting point. And then insomnia, asking about caffeine drinks. I cannot talk about that enough. And then abdominal pain, that is, I've been seeing a lot of that. There's a lot of the, symptomatic H. pylori, but also seeing acute gastritis, IBS, heartburn, constipation. So I treat that like I treat everyone, which is seeing them frequently, trying, conservative measures, and then sort of escalating as we need to. So I'm going to end there. These are some resources I just wanted to put that I reference frequently. They're not anything novel, but just the vaccine catch-up, population-specific information on specific, like the Burmese refugees, Nepali refugees, like the different populations. Yeah, so any questions?
Thank you so much, Shelley. That was wonderful. So much information, and I think it's really important for people to hear about. And we'll have this recording up on our website, and we will have the presentation. Once we receive it, we'll upload that to the website as well. There was one question which Andrea has noted that maybe she would like to answer, but it's who performs the domestic health assessment?
That was me trying to be helpful. Sorry, Shelley, that was just me trying to be helpful while you were talking, but I couldn't figure out how to answer it in the chat. So please ignore that. Yeah. Shelley, go ahead.
Oh no, just the UVM infectious disease does the domestic health assessments for most of the patients we see, unless they resettled somewhere else and migrated here.
Yeah, and to clarify, that's for anybody over age 18, and then our
Yes,
office,
and you do.
UVM
You do it all.
Children's, yeah, UVM Children's will do anybody 18 and under, and then infectious disease does anybody in the Chittenden County area.
Yes.
Because obviously now statewide it's being done a little bit differently.
Exactly. Yeah. So, and
And
I believe.
and I just want to.
Yeah. Oh, go ahead.
Sorry, I was just gonna say, I just want to thank you. I mean, that was just such an excellent and balanced presentation of strengths and resilience and also needs, and just you do it in such a culturally sensitive and culturally safe way. So I just really want to thank you for the care that you give
Thank you so much.
and the model you set.
Yeah. Thanks. Awesome.
That was awesome. Well, thank you so much. I don't see other questions. I think you covered a lot, and people have a lot of information to digest. So I think that's perfect. And I really appreciate you presenting and all of the people who've joined us today. So with that, I will end the webinar, and just again, a round of thank yous to everyone, especially to Shelley for presenting. Goodbye, everyone. Have a great afternoon.
Stop sharing.